The Adult Immediate Post-Cardiac Arrest Care algorithm begins with ROSC. The first action is to ensure an adequate airway and support breathing immediately after ROSC. Use the lowest inspired oxygen concentration that will maintain arterial oxyhemoglobin saturation between 92 and 98%. An unconscious or unresponsive patient will require an advanced airway for mechanical support of breathing if one is not already in place. Use continuous waveform capnography to confirm and monitor correct placement of the ET tube. Avoid ventilating the patient too quickly or with too much volume. Provide one ventilation every 6 seconds. Next, treat hypotension when systolic blood pressure is less than 90. When an IV is established, hypotension may be treated with an IV fluid bolus or various drug options. A hypotensive patient should be given a fluid bolus of normal saline or lactated ringers. Crystalloids, vasopressors such as epinephrine or norepinephrine, or an inotrope may be used. At this stage, consider treating any reversible causes that might have precipitated the cardiac arrest but persist after ROSC. Obtain a 12-lead ECG as soon as possible to identify early those patients with STEMI or ECG evidence of the need for percutaneous coronary intervention. For patients with ECG evidence of STEMI or a high suspicion of AMI, attempt coronary reperfusion. ECG monitoring should continue after ROSC, during transport, and throughout ICU care until deemed clinically unnecessary. If the patient does not have a STEMI and is hemodynamically unstable, consider coronary perfusion or mechanical circulatory support. Next, examine the patient's ability to follow verbal commands. If the patient fails to follow commands, the healthcare team should consider implementing targeted temperature management protocols and obtain a CT scan, EEG monitoring, and other critical care management protocols. After coronary reperfusion interventions, or in cases where the post-cardiac arrest patient has no ECG evidence or suspicion of MI, the healthcare team should attempt to determine etiology, obtain CT imaging considering pulmonary embolism, obtain laboratory analysis, and consider a drug screen. In addition, conduct an echocardiogram and transfer the patient to an intensive care unit. For additional information on each of the steps in the algorithms presented here, please consult the ACLS Provider Manual.